All right, thank you all for attending. Really appreciate your time, and hopefully this will be of some use and interest to you. As Deb said, so I am the Director of Education for Digit Soul, so that's sort of my disclaimer. I don't make commission on the sale of products, but certain organizations want to make sure that we do disclaim the association that we have with manufacturers. Um, so the title of this, Human Movement Locomotion Analysis to Inform Clinical Decision Making in the Rehabilitation Setting, and this has the twist to it of AI, artificial intelligence, and so my background in data assessment. So I'm very fortunate to work with and be trained by some of the top sports scientists in the world of our time for my master's and PhD. So that was kind of always the approach I've taken even in clinical practice. And these screenshots of this little young lady that I'm scrolling through was my daughter back before I was giving a presentation on motor development in conditioning for youth athletes. And ironically, this little girl, so she was diagnosed with gross motor deficiency when she was younger, just because she was having some difficulties learning how to walk, and it was a very interesting process to see the physical therapist that we were working with was just absolutely awesome, and so there's always been a really big component to utilizing this approach in describing how people move. So flat out description. So we're trying to create this base level knowledge of locomotion and gait analysis. And you'll see I'll separate, even though we're utilizing a lot of gait analysis principles, a lot of us refer to it as locomotion because of the technology that we have today and the information that we can gather from it. So this is sort of an investigation approach, as we refer to as like a level one. So we're going to have a series of courses that are going to sort of bring us through this journey and get a little bit more detailed with regards to the depth of information that we're actually going to get in. So this is really just more of an exploratory and sort of the thought process. So the two main key points are looking at locomotion or gait as a general movement analysis. I've been doing that for about 15 years, and my journey even through locomotion and specifically utilizing gait as a movement analysis. I had access to the lab I used to run, and because I come from a background in academia with Peak and Vicon Modus, motion capture, integrated force platforms, to what I'm utilizing today in the clinic, which was we're able to get a lot of information that we could only get in a lab, not even too long ago. And then how do we implement that? And that was really a big part of my academic studies, even aside from the clinical and the sports science arena, was how do we use this information to actually generate some of the clinical decisions that we are doing in taking care of our patients. This is like I always have these quotes that I seem to gravitate towards and use a lot, and usually of people that are like 10 times smarter than me, because it makes me feel better. But this is from Jordan Peterson, obviously an intelligent person, has certain views, but one of the things I've learned is the best way to learn about something is to talk about it. Um, and basically sort of implying that we don't necessarily always know everything, but when we start talking about it, specifically lecturing, and this has always been kind of my the benefit of having the job that I have, is I get to talk, and those that know me know I like to talk. So this is a great way that I really do investigate certain things. I like to push the limits and try different things, and I find that if we just simply abide by what is out there existing right now, then it's challenging to make us move forward. The other thing that I saw, I used to commute about 2 hours each way to the university, so I used to listen to a lot of TED Talks, and so Gosh, I think that one year I ran through all of them, and it was pretty amazing. But one of these other talks I really liked was, it was a medical physician, and his quote was, you know, I'd like to look at the historical perspective of whatever it is I'm talking about, because it gives us some sense as to how long we've been talking about whatever topic is at hand. And so I give a little bit brief of an introduction in the historical perspective, because it gives us a sense of like how long have we been talking about it and what's changed, you know, through the course of history of where it was and where we are today. Some definitions on gait and locomotions, looking at the pathological conditions, and then an example of the decision tree in terms of how do we utilize the information to provide hopefully better and quality patient care, and then, you know, sort of a conclusion. So the twist to this topic is really looking at artificial intelligence. And so artificial intelligence is not something new. It was what Turing who started talking about this back in the 1950s, but it's basically a science and engineering process, specifically computer science, and looking at how we can integrate the data collection process to create and formulate these algorithms that help to guide us in making some of these decisions. And I was not going to use this, but I did anyway. You can see the GIF file here. So this is an artificial intelligence looking at emotion, and obviously this is Will Smith from his little escapade at the Oscars. But you know, really interesting in how we're utilizing artificial intelligence in healthcare. So it's designed to sort of think like a human, act a little bit like a human, but ideally is to bring us to another level, right? And it's not to completely separate those two things. I think we've all seen enough movies where, you know, well, how do you know XYZ is going to happen? It's my gut, you know, and that there's a lot of benefit to that, and especially from the healthcare perspective, you know, we're dealing with humans. We are humans, and therefore not everything has its complete predictability to it, right? Remember when the clinical prediction rules, you know, were being developed, and now we kind of call them guidelines. One, because a rule implies that if you don't do it, it means you're potentially breaking that rule or necessarily doing something wrong. Instead, to say that, you know, it really provides us a guideline, and there's this deviation from that to make sure that we're within, you know, that channel of what is probably most likely going to be beneficial for whatever decision that we're gonna make. And then there's the machine learning component. So this is an aspect of artificial intelligence. And what this means is we're continuously informing the algorithms that we're utilizing for part of the decision-making process, right? The predictive patterns, by constantly feeding in new information, right? And what's interesting about this is as we continuously collect more and more information, it fine tunes, it improves. And like, to give you an example of sort of the non-motor learning, machine learning process. So I remember back when I was in undergraduate, and I was in competitive bodybuilding, for example, and one of the height weight charts we used to use at that time was still the Metropolitan height weight chart. Metropolitan meaning the insurance company. And according to that, even at 4% body fat, you know, is considered to be overweight by those standards, you know, always. And and the reason that's no longer the normative value is because we change. And that's what's interesting about motor learning, is constantly feeding these systems to update and upgrade. And I think sometimes we get hung up on normative values, and sometimes what might be the average of a population may not necessarily be normal. And I'll talk about, you know, some of our comorbidities that we're dealing with here in the United States in a few moments here. So machine learning is taking that information and constantly feeding into it to better develop the system, right? And actually, this is another Will Smith. So this is from the movie I, Robot, which 2004, 2014. Anyway, it was at least 10 years ago. And that robot, Sonny, this was an example of an artificial intelligent being, but also one that was involved in machine learning. So was becoming more human-like as it interacted with other humans to essentially be more like what we are as a biological creature. Now they use machine learning and they use artificial intelligence in all aspects of technology that we're dealing with today. But it's such an important part to us here in healthcare is it's helping us to make better decisions, but also with the efficiency aspect of things. So if I can do things a little bit more quickly, means that I can take care of more patients and so on and so forth. So the idea behind machine learning is another interesting concept to kind of see where we're going in this area of healthcare today. And it's such that it's not going away. And in fact, we've embraced it, right? Because the FDA even has certain classifications. If you have a device that has AI and ML embedded, which is artificial intelligence and machine learning, then there are some added criteria in getting a medical device, approved for that. So it is something that we have to deal with. And I skipped over the graphic, hey Google. So we have my clinic is smart, so I can yell hey Google right now, and it will respond to me. And so if you use Google, then you know that it will generate certain advertisements. It's a machine learning process in and of itself based on voice recognition to the questions that we ask and so on and so forth. So I want to tie that into what we're utilizing in our technology today, but let's look at this evolution. So this is, not a new process. I mean, evaluating human movement has been around for hundreds and hundreds of years, from Da Vinci to Galileo, and I spent a little bit extra time in researching Descartes because Descartes also looked at especially the cognitive aspect of things, right? Because we think of human movement obviously as very mechanical, sort of in nature, very physics oriented, but behavior patterns and thought processes do have a dramatic influence on our overall movement patterns, right? Just look at posture, for example. And then we can fast forward into the 18 and the 1900s, where it really took a leap forward, and that was because of technology, right? So having photographs, for example, gave us that opportunity to look back on something or do comparisons between a pre and a post, or between different people or different time frames. And that was instrumental at really being able to also look at some of these physics measures, right? The biomechanical measures and the metabolic or energy expenditure measures that we saw in the late 1800s, and then to what we have today. So the the continuous evolution of technology has also been kind of interesting. And so technology, from our standpoint as clinicians, we've also seen somewhat of an inverse relationship to advancements in mobility, not in how we deliver, but some of the things that we see in terms of what we're dealing with, right? So some of the conditions that we're dealing with may be a little bit different today than we saw 20 years ago. And even, as I talk to clinicians that have been around for a long time, and dealing with low back pain today versus 25 years ago is different, right? We didn't have to talk as much about behavior change patterns that we see today, and that's also going to lend itself to why we take a larger, broader spectrum evaluation in terms of human movement or overall and what's going on with the patients, because there's a lot of interplay. There's a lot of connection between obviously the different systems, but lifestyle, occupations, all of those things that interact with what we do in the clinical setting. And as I've always said, to other clinicians, we got to be careful, because if we put all of our eggs in one basket, if we take on the full responsibility of caring for patients, that's difficult. That's very challenging, because let's say they do make it into the clinic 3 times a week, an hour each time, 3 hours a week, versus the amount of time that they actually spend on their own and things that they're doing on their own. That's very challenging to take on that full responsibility for their entire compliance and movement capabilities. Also within the evolution and looking at how we address locomotion or gait, as a lot of people used to refer to it as, right? So that's the interaction, looking at forces, the effects, form, function, motion, gravity, intent, cognition, right? And so there's really sort of these multiple schools of thought. One is, okay, they come into the clinic and they've got a problem, so we evaluate what's their problem, or the performance perspective. Why aren't they able to run faster, jump higher? And then there's the prevention piece related to those other two components, in that, wow, look at them moving right now. They don't have this problem, but could it be a prediction to a future problem? So we're trying to look at all of these values and make a decision to intervene and to make some of those changes. Ironically, I was writing an article a few years ago for a journal on low back pain, and what was interesting is many of us clinicians will know this, and we will say, well, low back pain, yeah, it could be associated with, or probably is associated with, being obese and being sedentary. And in fact, we don't have a lot of those predictors, because a lot of our earlier statistics up until really most recently, and where we've gone with technology, is sort of this nonlinear approach. In other words, just as we gain weight, it doesn't necessarily mean an equal inverse relationship to some sort of change or metric. It's a little bit more complicated than that. And fortunately, technology is supporting us in making sure that we can sort of decipher and use this as a better tool than just that pure linear perspective. And also to look at it from a more global evaluation process to how it is that we're looking at, what's going on with our patients. So locomotion, obviously moving from point A to point B, all the influences that take place during that moment in time. A lot of us, might associate that with gait. And in the majority of that perception, you would be 100% correct, but there are certain implications, I think, that people have with just looking at it as a gait analysis, versus when we start to change up some of the terminology, people start to think about and look at things a little bit differently, and also be a little bit more open-minded. Because if I just say gait analysis to someone, they may think, depending on how long you've been around and what your education background and where you went and what you had accessible to you in the laboratory experience, as well as your clinical and internship before you got into clinical practice, what did that really mean to you? So if you were working with pediatrics, it probably meant something related to cerebral palsy, right? And that was one of the main reasons that gait analysis was even brought into this clinical setting, was, an evaluation process to look at the changes following an intervention or procedure, to make sure that essentially, we are on the right track. Gait analysis as a general description, looking at, well, locomotion, and it's visual, so it's observational, but there's also a lot of instrumentation involved that we now have access to today, right? So even that, I used to have in the lab, or I can go back a few decades and look at, my first interaction in a lab, and looking at human motion and analysis, and sitting there and clicking from dot to dot, and the amount of time that it took to get to that point where we could actually take some of those measures, and it would spit out a bunch of numbers. And then the next level was, well, what do we do with that? What does it really mean? And that's been a challenge, or the disconnect between what we see in the lab and what we see in clinical practice. And that's no different than even some of the applications that we also perform, is that, we don't always strictly abide by what a research paper might look at, and our own clinics actually take on a personality of their own based on how you treat, because you are human, and the people that you're dealing with, which are obviously also human. And sometimes there's that interplay where you may attract a certain type of patient. Sometimes it's just, based on healthcare and the reimbursement scheme. So when I say gait analysis to a lot of people, this is kind of what they think about is something in a lab where, yep, we've got this motion capture system with multiple digital cameras and force or pressure platforms, and we can generate a multi-segmental model of the human. And what's interesting is when we do that, I mean, you completely remove, the face of the patient, and we look at it purely from that calculative, model, when again it goes back to the fact that they are in fact human, right? And when we look at this motion analysis process, and I still see this from a lot of people, a lot of practitioners, and some of them are that good where they can visually, watch somebody move and have some level of determination. Not everything requires a lot of that minute detail, and arguably, we may say that it may cloud some of the judgment, but there's a very similar process whether you're using instrumentation or not using instrumentation, if you're using locomotion or specifically gait analysis. So some of the barriers that we've seen are, like I said, that disconnect in what we learned in school, what might be in a high-tech lab, and what we can actually perform in clinical practice, right? And if your experience was such that you went to an institution, and one of my big complaints was, I've got this wonderful lab, but I've got 250 students. How do I give each one of them, enough time to really gain the experience? So there's a limitation in that. Cost is another huge one. How can we get that type of information? Because if it really does matter and it's really beneficial, shouldn't it be available to everyone, right? And then it's, how do we implement these sorts of things? And I think in the last slide I talk about adapters versus adopters, right? So the implementation is also a challenging process. Where does it fit in, right? Just because, something new comes out, if you've been in clinical practice, you've been doing that for 20 years, 10 years, even 5 years, is it feasible to make complete changes to your practice approach to implement something? And if you do that, how does it meld with what you're doing? How do you create that overall successful model? And I think that's where some people have another potential barrier is it is challenging, right? Healthcare reimbursement's constantly changing. As surgical procedures change, as the mentality of our patients change. And I always also ask people, is technology, required? And I have a quote down here, nice jump shot, Dr. Prue. So I used to do this thing with my students, and I would do a video of me performing a jump shot. And I don't know if any of my students are on here, but if you've seen that video, I look like Michael Jordan. I mean, that's how good my jump shot looks. And then we do another exercise to where we actually look at some of the end results, which is, does the ball even go through the hoop? And the answer is not very often. So despite how good it might actually look, there are some issues going on to where, the outcomes are just simply not there. And I might need to look at a little bit more detail to determine, what exactly is going on. And I think that's probably one of the best approaches to utilizing technology to informing our clinical decision making process, right? So this is just, on a treadmill, barefoot, wearing shoes. And I know some people will say, yep, they're good enough. They can actually do that without, technology. And maybe, but for most of us, that standard deviation is pretty small, and it can be a little bit challenging. Even just to look at what I call the variances, right? So when I do something to a patient and it causes a change, maybe the mean, maybe the average doesn't change, but the variability might actually change, and that's significant. And that actually gets back to what's referred to as like the symbolic complexity, right? To where a lot of these changes, both from a pathological perspective to non-pathological or human performance, are not necessarily purely linear. And in fact, we kind of know that it's not linear. And so if we take that little bit different perspective, we might get a little bit more information from it. That's very challenging. And that's where the AI comes in, right? The artificial intelligence that can really guide us through that. Otherwise, it thinks like we're supposed to be thinking, but it has much better computational methods than I do in my head, based on the amount of time that I'm gonna take with my patients. So real basic, most people are quite familiar with this. And when we look at and analyze and utilize gait as locomotion assessment, we kind of break it down into a few different areas, the step and the stride, which we also have a swing phase. So we have some normative values at certain speeds. And even as we make changes to those speeds, and this is kind of the first introduction to show that those changes are not completely linear. So for example, one of the things that I do with patients is I have them walk at a very comfortable pace. And I'll show you an example here in a second. And you have them walk at a comfortable pace. And in fact, what may show up is everything's normal, right? There are no asymmetries. The variance is really low in all of these characteristics, from the stance phase to the swing phase. And the percentages are there, right? So basically we spend about 60% in the stance phase and about 40% in the swing phase. And that's pretty standard. As we start moving faster, some of that changes. As we start running, it changes dramatically, right? We no longer have a double support phase. And so that changes everything. And again, it's not purely linear, and that can be very, very challenging. The other thing that's also challenging is to look at some of the biomechanical and the neuromuscular aspects. One of the other reasons I like to use locomotion or gait as an overall assessment is the integration of all the systems associated with those patterns, which, I call it sort of the window to the health soul and the human movement soul, because it integrates a lot of those things, especially when we have that ability to look at some of that detail. And I know I get a lot of pushback. People are like, do you really need that detail? I think, do you need it? Well, we can certainly use it, and I'll talk a little bit more about where I think that might be important. So we can further break down the stance phase and the swing phase, because again, from an observational perspective, you can see that, but are you able to really capture all of the data that might be important? I'm going to show you a list of conditions, pathologies that influence locomotion or gait, and they don't all influence the same component within the stance phase or the swing phase. And sometimes it's just changes in variability. Again, because it's not it's not a linear relationship at all, especially once we start to see these pathological conditions. I call this sort of the basics of locomotion assessment in my dashboard, right? Symmetry. Essentially, we were designed to be, well, somewhat symmetrical, not 100%, and you typically don't see someone being 100% with regards to symmetry. So this specific measure is looking at the symmetry in the contact phase, how much time each foot tends to spend in contact with the ground. There's actually supposed to be some variability in there, right? And that's your buffer or your cushion. And it's that variability that allows us to adapt to the changing environment, right? And something that's very popular right now is like heart rate variability. So we know that the variability is an important aspect of the overall health, to show that it can actually sustain, stressors to make those changes. And in locomotion, you can refer to that as the complex motor theory, where we don't want to be completely symmetrical. And that actually shows that, you've gotten so used to something that it could be very challenging to disrupt that and come out normal on the other end. So symmetry is really good. And oftentimes, depending on your statistic, somewhere around 10%. Speed. So speed is another really interesting and basic statistic, and I'm going to use this one to highlight, a case example here in a moment. But so we have some normative data, and a normal adult. So if you tell them to walk from point A to point B with intent, right, because you want them to get someplace, they're not in a hurry. They're not trying to catch a plane or anything like that, but they do have intent from going to point A to point B, and they want to be there on time. That average is 3.0 miles per hour, right? Or about 5.1 kilometers per hour. So when you ask someone to do that, that's about what they should be at. The other reason that that's a potential key variable too is now I'm going to bring out, okay, so now if I'm dealing with health, so I got a patient that comes in with a condition, and if they can't walk at that particular rate, that also is going to tell me, even if it's an ankle problem or a knee problem, it does tell me that they're not going to have a really good influence if they're using gait or walking as a way to stimulate metabolic expenditure, right? Aerobic capacity, the cardiovascular system, minimizing heart disease or something like that. So that's it's simple, but it actually provides us a fair bit of information. Cadence. So this is again where I don't have to run the numbers. So if you have an AI system, something that shows you the cadence, that's simple to calculate. But whether or not it's normal based on, the patient metrics or demographics, limb length, body weight, and things like that. So cadence is interrelated, obviously, to speed. So movement analysis, what can we actually use it for? This is where it's challenging. It's another place I get into a little bit of discussion with people where they can throw out literature that says, you know what, gait is not influenced by low back pain. And I would argue and say, well, it really also depends on how you measure it. What parameters are you using and what metrics are being evaluated? Because again, it is not a completely linear process. It's not linear at all. As I keep saying, it's a curved linear process. Even behavior pattern, as we find the increase in mental health issues today, even as a result of COVID, we have to be cognizant of that and how that influences gait. Here's a cool thing too, to think about when we look at all the conditions that are influenced by gait. How could we then also use gait, right, as one of our treatment methodologies? Because if it's multi-system influential in locomotion, likewise, could we therefore not use gait? And most of us do. Basic, neuromuscular cross crawl patterns, really simple, but very influential on the overall programming. Remember back in the 1990s, the evaluation of low back pain programs, for example, was that, the programs that tend to be most successful did involve some aerobic activity, such as walking. Neurodegenerative conditions. So how is this so? What was interesting is, and I used to be an athletic trainer too, so impact testing was a cognitive test that we used to use as a baseline. And if someone was suspected to have a head injury, such as a concussion, traumatic brain injury, then we could use that as an evaluative process to determine whether or not whatever the situation that they were in influenced their neurological state, right? And then further development of that actually shows that conditions such as Alzheimer's are also influenced by motor. So even with the traumatic brain injury, we know that motor function, movement patterns, gait, balance are going to be influenced prior to cognitive. And when we are looking at return to play, we also see that on the other end, that it returns later than the cognitive aspect does. So it's a potentially more sensitive measure to determine whether or not whatever it is that we're doing is having its influence, or whether or not their state of affairs is actually improving. So that's another interesting aspect to look at why, locomotion or motor development. Obesity. Obesity does have a tendency to change gait, and I'll talk about comorbidities here in a moment. And what's interesting is if we want to utilize some of these relationships, and they're not even all cause and effects, but when we look at something like the velocity and vertical loading rate, that if that is elevated, even though we don't necessarily have a pathological connection at that moment in time, why can't we use that as an opportunity to talk to our patients about what might happen a little bit later down the road? And this is even interconnected with osteoarthritis and chronic pain, which, by the way, is in the top 5 list globally in terms of healthcare expenditures and relative percentage to the GDP of most any developed and undeveloped nation. So making sure that we treat pain appropriately. But here's a concept, maybe we could potentially minimize that moving forward. Spinal pain, number one. And so low back pain and neck pain constitute about a billion people globally at any given time with regards to what's happening. So related to this and utilizing this, not only if we get into the evaluative process of what assessments give us the best kind of information, is locomotion, is gait assessment that sensitive? And I would argue if it's done correctly, then it actually can be highly sensitive, especially if you're using, a point care plot or some symbolic, curved linear purpose to it. But also, is it that specific? And the answer is not really. And to me, I'm actually okay with that, because what we do find is the interplay with all the different body systems that are influencing gait analysis. We actually use it as an overall aspect of health. And the reason that, if we think about why that's going to be important, other than just having a focus on a specific diagnosis, which we've moved away from, right? I mean, that was the reason for ICD-10, right? The International Classification System was not just about labeling whatever their diagnosis is, but also looking at the dysfunctional aspect of their condition, right? If you remember back when there was the vision of APTA for 2020 was to be the wellness practitioners by 2020, right? And I don't care if you're in physical therapy, podiatry, chiropractic, there's a lot of overlap and similarities. And here's the ACA: healthier and more productive lives for the American people. So what does that mean? And that's why I always bring up the comorbidities, because I would challenge someone, if they're only going to focus on the osteoarthritis knee pain of someone who is in fact obese, how much difference is it really going to make in the long term? Because that's another metric that we use in healthcare spending dollars, and why surgery can be equitable, even though we know on the back end it costs a lot more. But it's because of the amount of time spent in those conditions, the repeat of having to go through the same processes over and over again. So we look at the obesity rate of over 40% of adults in the United States. The sedentary is about 66%. Prediabetes is over 50%. And I think we're hard pressed to see many of our patients that come in, unless you're dealing specifically with a very active population in sports, that don't have those comorbidities. So it would make sense to have some sort of influence in evaluating the overall condition of our patients. And that's where, again, the sensitivity and using something that has the artificial intelligence capability to it, but the motor, the machine learning aspect of it, that's constantly feeding into the algorithm to keep us most up to date in how we are in fact evaluating patients. So I'm using this as a case. I spent a lot of time in high-end sports and youth, and so it's not dissimilar. I just think, with the older adult population, I was just watching a documentary the other day on the over 90 age group, 90. They are the fastest growing age group, which is crazy. And there's some really cool and interesting data on that. So here's a patient profile: 83 years old, female. Initially, the presentation of cervical myelopathy, but also has bilateral knee pain, a previous history of knee pain and osteoarthritis for about 50, 60 years. So long-term knee pain, decrease in physical activity. Interesting. History of falls, multiple falls, including hospitalizations, several medications. I mean, your typical brown bagging it, including mood altering. So migraines, amitriptyline for almost 50 years. And actually, I was having a discussion with a clinical psychologist, and I said, a patient being on amitriptyline for that long, and it wasn't for depression, because, right, that's a side effect with a tricyclic antidepressant, is you get decreased headaches, and that's why they started using it for those patients. I'm not knocking it, but then when you take something like that away, that does increase or change neurotransmitter production, release, and interaction, and then you take something away. So if you change up that medication, it has an influence. lots of upper extremity weakness as a result of the cervical myelopathy. She went through a course of physical therapy and occupational therapy because she had another severe fall, um, tibial plateau fracture, orbital fracture, and fracture of the radiostyloid process. And so coming off of rehab, and actually it was the in-home rehabilitation that seems to really cause some. She has really poor posture, so I'm not saying the rehabilitation was causing the problem, but it just brought to light her poor posture and very severe degeneration, multiple levels, osteophytic changes, and central canal compromise, in the cervical spine. So, amongst everything else, so we did a movement analysis on her. One, because I'm really concerned about her history of falling, and she's going to go ass over tea kettle again if we don't correct that aspect. So yes, we are concerned with her cervical myelopathy, but does that play a role in some of her issues? Most likely, just because of her pain and discomfort, decrease in mobility. She is independent living. So her symmetry was great. She's at 91%. But then we look at her other characteristics. She's only comfortable walking at right around 1 mile per hour. So what does that tell us? Well, she's very slow, poorly conditioned, so she can't walk faster. And if you ask her, she actually has a fear of falling because she's been scared to death, almost literally, in her falling, and as a result of really slow speeds, she has a very slow cadence. So then you look at, her walking profile, very short step and stride length. She spends a lot of time in that stance phase. And this is very typical of someone who, older adult, fear of falling, predictability of falling. And then we can further break that down, and where, again, I can't see this with the naked eye. And as you can imagine, she moves very, very slow, so her strides are exceedingly long based on the speed at which she's moving, and her stride lengths are very, very short. So in other words, she's spending a lot of time in a stride for gaining very, very little ground, so it takes a long time to move from point A to point B. So we do see also an increase in the swing time, but just look at the deviation in the swing time. And again, in that stance phase, it makes sense. She spends a lot more time on the ground because that's where she feels more stable. And then here's a really cool output that we find in the gait line. So the gait line is looking at the transition or the trajectory of the center of pressure as we're moving through that stance phase. I like to spend a lot of time thinking about the stance phase. Well, I I look at the stance phase, and the reason is because that's where someone is supposed to be most stable, right? And so I like to really evaluate that because that's where they landed and that's where they're taking off. And so it really makes sense that they need to be able to land in a safe spot and be able to take off to go through that next swing phase. So this is where, the AI algorithms come in, and obviously it's going to calculate those relative percentages. So you can see that, she's pretty close in the amount of time as far as the percentages, but you can see in foot flat, she spends, about 3/4 of that time. So she doesn't like to spend a lot of time in heel strike. And think about that, right? So that means that she doesn't have a lot of surface area in contact with the ground. Same thing in propulsion. She wants to get off that foot as quickly as possible so she can be foot flat again as much as she possibly can. So this is where the algorithm, the AI component, gives me some indication, and it talks about her very short propulsion times on both the right and the left. And you can see that she's pretty symmetrical with regards to her problems in what's going on. And as a result of that, it also gives us some indication as to what is going on sort of kinematically, even though we're not measuring kinematics, with motion capture, what's going on at the knee and potentially the hip, and why I also watch them walk as we're performing this. Related to that gait line, if you look over at the foot progression angle, so that's looking at the amount of external rotation and the amount of circumduction. So this is also going to influence how she's going to come in contact with the ground, and frankly, why she spends so much time in contact in foot flat position when you look at the that right foot with regards to the amount of circumduction. And again, an AI analysis report gives us some indication. So it calculates this for us and then gives us a relative interpretation. You can see that she has learned, right? Because she's had this problem for a long time. She's using pretty decent foot clearance. And so when we evaluated her history and we looked at, well, when did you tend to fall? And it wasn't that she tripped over something, it was that she lost her balance. She just didn't have the stability. So she's got pretty good clearance. It's just that the angulation that she was heel striking. So she tries to strike with a foot pattern that is relatively flat. And so she uses kind of that shuffling gait. And again, we see that she does have some sufficient steppage, but the angulation that she's foot striking is relatively short. So the considerations that I'm using here is obviously looking at those things that are otherwise considered to be abnormal and give me some indication as to what we should be doing. Now, could I pick up some of these with the naked eye? Quite possibly, and maybe I've been doing this for a long time. But again, when I perform an intervention, I also look at some of these changes that even if someone is still within that sort of negative or pathological range, but they've made great strides, no pun intended, that's actually indicative that we're on the right track and things are moving in the right direction. So for this patient, we did want to manage her knee pain. That seemed to be a contention for her, improving her extensor strength, very weak in the hip extension and knee extension moments, which is why we don't like to see a really high loading rate on people like that. She just doesn't have the capacity for it. We want to reduce her overall fall risk. So we certainly needed to address where she was lacking. And again, the outcome of this also gives me some other reasons to look at, perform some of the other tests, and coordinate some of those strategies in my intervention. So there's nothing out there, unfortunately, that's going to say, hey, here's exactly what you need to do, right? And to me, that's the difference between being the clinician and the technician, is making sure that we're able to address all of that. So I mentioned this earlier, adaptation versus adoption. So the adapter is someone who can take something and basically make it fit their particular model, right? And that's what I find is easier for a lot of people in clinical practice. And it makes sense too that, to have to reinvent your entire clinical practice, if you're doing a halfway decent job, it kind of makes sense that you shouldn't have to do that. How can it fit in? How can I use it to inform myself? So I look at obviously informing my decisions, right? What's going on clinically? Does it do a better job at assessing what's wrong with my patients? Does it assess my interventions? Does it show progression? Does it improve the efficiency within the clinic setting, right? Because if this is a better assessment tool that takes less time than something else, that also makes sense. A big one for me is compliance. I'm very candid with patients, and I put a lot of a lot of emphasis on their empowerment. And I think that when we can show them specifically what's going on with them, it's a very powerful tool to get them invested in the overall process, and to know that we can test this with some degree of sensitivity to know that they're actually being compliant and they're doing the things that they're supposed to be doing. So as an overall assessment tool, certainly, other than the lower extremity issues, and that's why I refer to it as locomotion, because locomotion is, I think, on a larger scale, it's a little bit higher view in terms of the terminology that's being used, a better umbrella to thinking about gait analysis. So I look at a lot of the variations, a lot of the changes, but as a whole, what is going on with the patient? and what is changing with regards to the implementation and the intervention. And then I kind of skipped over one of the points on my previous slides that had comorbidities. And so by 2030, it's estimated to see an increase in joint replacements, total joint arthroplasties by 300 to 500%. My goal is to hammer away at that percentage. I think that's a lot, and instead of, just waiting and management by crisis, being able to inform our patients, as I said, doing a better job at, being the go-to person to make those changes. So this is my daughter now at age, she was 9 here, that, fortunately she has a daddy really invested in human movement, and so she went from having deficits in gross motor patterns to what we see today as a competitive little athlete. So thank you for your time. I know we've got a few extra minutes if there are any questions, and our sponsor digitalpro.com. You can go there and look at some of their analysis solutions. Be on the lookout for, we've got 2 more courses coming up that are sort of in line with this, and we want to kind of bring it to the next level and talk a little bit more specifics as to the utilization of the information.